Hey guys, welcome back to Clinical Physio. I'm Khalid Maidan, and in today's video, I'm going to be taking you through my top tips for plantar fasciitis. I'm going to be guiding you through the key anatomy you need to know, as well as the best ways to diagnose and treat this condition. If you enjoyed this video, we'd be super grateful if you could smash that like button and subscribe to the channel for all our best content. But otherwise, if you're ready, let's dive in. So, the plantar fascia. This structure is located on the sole or plantar surface of the foot. And as we can see, it runs from the calcaneus or heel bone to the distal digits of the foot. Now, it's important to say that the plantar fascia is not a muscle or tendon, but as the name suggests, it's a fascia, a connective tissue. Its main role is to maintain the longitudinal or medial arch of the foot through what we call the windlass mechanism. The idea being is that when we extend the first digits in particular, this tensions the plantar fascia. By tensioning the plantar fascia, it actually lifts the arch of the foot and acts as a propulsion mechanism during gait. Okay, let's dive into diagnosis. What are the key things we need to know for diagnosing plantar fasciitis? Well, it's really critical that we listen to the patient's story, as the subjective history is going to give us the majority of the clues that we need in order to diagnose this condition. So, we're looking at predominantly pain at the calcaneus, particularly on the plantar surface of the foot. As we saw from the anatomy model, this is where the plantar fascia originates, and actually patients often describe pain at the distal calcaneus as well as the medial aspect of the calcaneus. We know that the medial plantar fascia is irritated a lot more than the lateral side. You often may find that patients will present with a gradual worsening in their symptoms rather than a sudden onset. And the most common classical sign for plantar fasciitis is pain on the very first steps, weight bearing after your patient wakes up in the morning. And you'll commonly find this in other parts of their day as well. So, for example, if they've been sitting on the sofa for a long period of time and then they suddenly go to stand up, or if they've been driving for a period of time and then they get out of the car. Those first few steps after a period of rest is, again, one of the most classical signs for plantar fasciitis presenting itself. But also look at other weight-bearing tasks such as walking and running. Do they get an increase in pain the further they walk? Do they get an increase in pain the further they run? And unfortunately, we know that plantar fasciitis can be a really irritable but also quite a chronic condition. Only 50% of patients recover in the first year. And if we look at patients with plantar fasciitis over a 10-year period, only 2/3 of them recover. There's still a third of patients after 10 years who have quite irritable symptoms. So listen for that when it comes to your patient's history. So we've said that the subjective assessment is the most critical part for diagnosis, but of course we also need to objectively examine and assess our patient. So the key things we're going to be looking for here is going to be pain on palpation of the calcaneus. Of course, as we've said, that's where the plantar fascia originates from, and we're looking to see if we reproduce the symptoms that your patient described in their subjective history. We may also look at the function of the tibialis posterior muscle. That's because this muscle also has a role in maintaining the arch of the foot, like the plantar fascia. So if you find that your patient has a weak tibialis posterior compared to the unaffected side, that might start ringing some bells for you as to why the plantar fascia is as irritable as it is. And then finally, we might also look at pain during weight bearing, particularly during weight bearing dorsiflexion. So the way you can do this is by looking at the knee to wall test. This is where your patient stands with their foot flat on the floor and their knee on the wall, and you're looking to see if this reproduces your patient's pain. Even more so, if you extend the big toe or the first digit in that position as well, this is going to load the plantar fascia even more. So if you find that that position is irritable for your patient, that might also give you some more clues for diagnosing it. So how do we treat this condition? Well, in the past, we've often looked at loading strategies, particularly with exercises like eccentric heel raises. However, recent evidence is actually taking us away from this idea. Morrissey et al. Completed a fantastic systematic review on how to treat plantar heel pain in 2021. And they found that there are three core principles that we should use in order to treat this condition. They are stretching, taping, and education. So let's dive into all of those. So starting with stretching, there are a lot of common stretches that you'll see for when you want to stretch the plantar fascia. The ones that I look to the most include when your patient is in a sitting position and they have one hand on the calcaneus, one hand on the toes, particularly that first digit, and then they're pulling their hands apart in order to stretch the plantar fascia. But you also may be familiar with stretches like you can see on the screen now, including a towel stretch, particularly when the towel is over the toes of the foot and we're pulling back in order to stretch the plantar fascia, as well as hanging the heels off a step or a calf stretch standing against the wall. My personal favorite is the first one I showed you with the patient sitting and then pulling the toes apart. But for that patient who does find that their symptoms are irritable first thing in the morning, you can suggest to them to keep a towel by their bed in order for them to do the towel stretch first thing before they get out of bed. So in terms of taping, you might find that there are different ways of taping the plantar fascia. The one that I tend to find works best for me the most is when you apply taping to try and maintain or support the medial arch of the foot. And that's because, going back to the function of the plantar fascia to try and maintain that arch, if the plantar fascia can have some help in order to do its job, it can make it a lot easier. So as you might be able to see on the screen, I use this method where you are trying to, once again, maintain the longitudinal or medial arch of the foot. But other variations do exist, which are said to be useful as well. So that third aspect we talked about is education. And of course, we know that patient education is critical to any musculoskeletal condition, and plantar fasciitis is no exception. So here we're talking about a couple of different things. We're talking about things like weight loss. We're talking about the use of painkillers and monitoring pain levels through the day. We might be talking about simple measures like rolling a cold can on the plantar surface of the foot, which can sometimes help to eradicate symptoms. But a lot of it comes down to also load management. And here we talk about modifying your patient's activities to try and reduce the load that's placed on the plantar fascia. So how much walking they're doing, how much impact activity they're doing. And also footwear. Naturally, this is going to be a big part of things. So your patient might find that it's more comfortable using footwear with a more supportive arch, with more comfort that's going to make their symptoms less irritable during the day. So these are all things to discuss with your patient who has plantar fasciitis. So the review from Morrissey et al. Highlighted that those three key pillars during the first 4 to 6 weeks should do the trick for most patients. But if it doesn't, then the second layer of treatment might look into shockwave therapy. This is something that we're seeing more and more commonly used for soft tissue injuries. If that is found to be ineffective, then the third layer is looking at custom-made insoles, again, to perhaps look at maintaining the medial arch of the foot. And they found that there is some, but perhaps low evidence for the use of a steroid injection. But ultimately, their review highlighted to us that those three core pillars of stretching, taping, and education is the most important thing to do. Now, if you're watching this video, please don't take this as strict medical advice. Any patient always must be assessed and treated within the musculoskeletal physiotherapy capacity, whereby an individualized program is most used for them. But I hope that this video can give you some tips to help you on your journey. Thank you so much for watching. We really hope you've enjoyed this video, and if you have, please have a look at the links below in the description for details of our social media channels, including our Instagram account @clinicalphysio and our website clinicalphysio.com, which has got all of our best information for you to use. My name's Khalid Maidan. Thank you so much for watching, and we'll see you really soon right here on Clinical Physio.